Hi there, it's Dr. Scott McLean, and this YouTube video will show you how to replace an implant after it's come out. You can see that this implant in the upper patient's left released after being placed. We placed an upper and lower bridge on this patient. So you can see here the bridge was taken out. We can look at that. It's a nice looking bridge. This is a transitional, and you can see we put some acrylic in the chamber just during this procedure and relieve the occlusion because this is during the healing phase. And so we had a new upper bridge on the bottom and a new upper bridge on the top. And after just about 3 weeks, the upper implant just released. We did an intraoral scan of the transitional bridge, and this allowed us to do some planning in DTX Implant Styudio with a new CBCT x-ray. So we put the two together and we can plan where the implant's going to go because it's going to have to go in a new position after 2 months of healing. And we can see here, placing the implant, we're going to put this implant up underneath the implant that's already placed and up against the sinus. So this is the all-in-4 position for placing the implant. And you can see the guide's going to help us to do that. So the guide will actually go on the transitional bridge. So we're going to use that to position it and know exactly where the implant should go. So it's pretty cool. We used an 18 millimeter long implant just to get the 2 millimeter first drill. And so that's what we're after here, is to get the drill. And I'm going to show you the actual surgery and show you how we fix this bridge for the patient. So the guide is going to fit over top the transitional bridge. So transitional bridge is just a healing bridge. And so this implant didn't heal, but the other 7 did. So we're going to use this position to position the new implant. So we'll use a 2 millimeter twist drill to go in. And this is going to allow us to position the first twist drill so that it's going to be drilled into the patient's upper jaw, so that we can position that implant and use a series of drills to do that. So as we go along, you can see I can take the guide, and I'm just going to use the 2 millimeter. I'm not going to go any more than that. The rest will be done freehand. So we'll take that position, and of course, why do we go freehand? Because there's going to be acrylic that could possibly go into the osteotomy, and we don't want that. So we just want to get that first position. And so I'll go back and forth a few times just to make sure that we get some of that acrylic so it's got a passive fit. So I'll put this in some chlorhexidine in a sterile bowl. This was purchased, and then we can sterilize it and use it to actually put the whole bridge in. So we replace the transitional in the patient's mouth, screw it down with the prosthetic screws. And those that do all-in-4 will know exactly what I'm talking about. But putting the implant back in is actually almost just as much work as putting all the implants in before, but not doing it this way. As you can see, I'll tighten it down with a unigrip driver and get this positioned so that we can then put the template on and place the implant. So we get this in position. The patient's doing quite well. He's very relaxed. We had 0 problems with the other implants during the healing because we took the implant out, let it heal for 2 months, and now we're going to place this back in. Then we'll start to load the teeth again and get this into, the patient's quality of life has never really changed. We're able to see that we're placing the implant right up under this area, so in between the sinus and the first implant, because he had some poor bone in the second quadrant. So we're able to bypass that and angle things. It looks a little bit more angled just because of the x-ray. But, and we'll get that in that pre-sinus area. So just ahead of the sinus is that really high quality bone. We're going to place a nice implant in this area. And we want to hit this bridge with this spot. So we're going to be able to place this implant in nice rigid. So this is not the actual implant that we're going to place. We'll click this down because we want to be short of the sinus. So the goal is to trick the software, because we're going to use an 18 millimeter drill so we can get the ring into a guide on top of the transitional bridge, because you can't typically do this. Usually this is sitting on the soft tissue of the arch. So We're just trying to get the first maybe 8 to 10 millimeters of the 2 millimeter drill lined up so that we can then use that osteotomy to finish the drilling protocol, because it gets us on the right trajectory. So it's almost like we're doing a guide within a guide. And so it's tricking what the systems are and having it so that we have the ring into the guide that's sitting on the bridge. So now we have the 2 millimeter drill going in. You can see there's how much is going to drill into the bone to give us the angle of what we want to do with the placement of the new implant. So we'll take that out. We're not going to use that guide anymore. We are placing a 11.5 by 4.3 noble active implant in this site. And so we're going to do this using a non-guided protocol. So we're switching from a guided to non-guided kit. We will use the non-guided kit to show the angulation using a guide pin. And this shows us we're dead on here. It's like amazing. I'm quite excited, and you get adrenaline even though you're redoing something. It's never fun to redo your work. So then I'll take a tissue punch kit. I'll put the disc in, and this disc will line me up to where the actual disc will be cutting. So you can see here, this is a little bladed tool that will fit over the disc, and we'll take out a piece of the tissue so I can get in and do the work and have 0 sutures and 0 pain after this procedure. The patient's going to feel amazing and really not have any issue. So we take the disc, cut it, and take the guide out, and then we just take a molt and take this molt elevator and take that piece of tissue away. So it's a pretty simple procedure. And now no sutures, so we've got instant access into where we want to place the implant. So in a second, we're going to look at this golden triangle, I call it here. You can see I can go in with an 18 millimeter drill and actually have the tip of that go in about that far right there showing on the x-ray. But we're not placing an 18 millimeter implant. Don't get confused. We're going into this triangle, which is the best bone, and we're going to switch back to 11.5 millimeter 4.3 noble active implant so I can go just up underneath the sinus. And as I do this, you can see we're getting a non-guided kit. And the non-guided kit is going to allow me to do everything now with my feel of my hands. So I've got the 2 millimeter drill. That osteotomy started at about 8 millimeters probably, I think. And you can see that when we have this all together, we're going to go in, and there's the angle. Okay, so that's the angle. We know we want to pick up that angle and follow that. So I'll put my drill right next to that to really pick this up. So we're going to go with a 2 millimeter twist drill, which is a straight drill. There's no step in it. So it's going to be able to follow that first shortened part of the osteotomy. So we'll go in and we can slide the drill in. So you slide it in and you don't turn it on until you're in there. So you can have the angle, and then now we're going to start the drill and get the 800 to 1,000 RPMs going so that we can put that first drill into the final position. So it's following that first part of the channel, and you have to let that follow. So you have to let your hand follow this. And so then we're going to get the step drill. And the step drill, the middle part of the step drill follows that first 2 millimeter drill. That's why it's called a step, because the inside part is going to follow the first one. And we can see as we do this, we're going to go full depth because we want to get right up to the underneath of that sinus. We want to have about 4 millimeters of soft tissue the way I've measured this. We should have that, and there's lots of tissue here. This chap has some really good tissues, and this will help for the long-term success of this implant. This is a minor speed bump to fix this, but we've got to fix it right. So we'll go in with the next drill. And you can see we went to the 2.4, 2.8, and then we go into the 3.2, and we only go halfway. So by going halfway, we're going to get some excellent stability. So we want to have at least 35 newtons of stability, but with the Noble Active, we're going to have 70 newtons of stability on this implant. I can feel it. You can see the TiUltra surface of the implant. It's gray with this gold part, and this is anodized. Look at the blood go up this. It's so hydrophilic. It's just sucking the blood like it's just bringing it right up the implant. So it's amazing, really. It's so hydrophilic, and that's what we want when we're placing an implant. We want blood all over it, and we want this to help with the osseointegration. So as we're putting the implant in, you see it's stopping, and so I'll actually feel this with the torque wrench. So I've got the gold torque wrench because that's the high torque wrench. It's a 70 Newton torque wrench, and so this is what we use for the Noble Active. And so as we put this in, we're getting some nice torque. And so I know this is going to be helpful because I want to load this. And so I'm going to actually take this, put it into position, and have the patient so that he's going to go and not have any pain the next day. There's zero pain because he doesn't have a cut. He doesn't have any sutures, nothing to remove. It's just we're going to have to let him heal. And so you can see that the tissues are quite good here. So we're going to make sure that we've got lots of tissue around this, so we'll go up to the base of the sinus. So I know from the DTX Implant Styudio and the DTX Styudio, actually on this case, we can see that that the implant is very stable. So we're at 70 newtons, and this is what we want. So the implant is recommended to be at 70 newtons. There it is. And so we can get this to the point where it's double what the research shows. We want to have at least 35. So we've got 70, and that's what the manufacturer recommends. So you get it. I love that. That's incredible. So we're going to put an abutment on. This is a 30 degree by 3.5 millimeter multi-unit, and you should be using multi-units on all bridge work, whether it's all in 4 or whether it's 2 implants supporting a bridge. I like to use multi-units because they're a zero bone loss concept. You get soft tissue, platform shifting. You have the platform shifting where you want it. So it's going to create long-term bone stability because of this. And there's the CC bone mill, and this is something I actually designed. So the CC bone mill was, I found there was a void way back in 2007. So I designed this, and Nobel actually made it. And you can see the bone mill is going to cut a 5.2 millimeter area for the knuckle of the 30 degree multi-unit to go in, because it's going to bend and bring it back to parallel to the surface of the teeth. And so as you put this in, this is going to allow you to trim the top part of the bone so that if the bone is in the way, the abutment's going to be able to be seated. This is critical. See how the bone is in the way here? You can see there's a space right here, right there. And so that space, when this goes down, it's going to cut the bone so that the knuckle of the multi-unit abutment is going to be able to come up to the bone. And this is really where we used to have to do this with hand pieces and stuff like that. This allows it to be done with a milled type of, it's a bone mill called the bone mill CC. And you can actually do this on every conical connection implant that Nobel has. And it'll make your life and anyone doing the prosthetics. I'm doing the surgery and the prosthetics on this case. So you can see here, once we put the multi-unit in, that it's going to allow me to seat that. So we want to check this to make sure it's in the right position so that we can pick this up in the bridge. Because remember, I designed this so it's going to hit the bridge and then come through the bridge, because that's also another problem with this, is that we want it to all line up again. And so you have to line up where the implant is, but you also have to line it up to hit the bridge. This is the critical part. And so that's going to support it for the patient for the long term. So there it is. We can see it's needs a little bit of a positioning. So we'll unscrew this, and we'll get this to be in this position that we want it to go in. So the goal is to do this and get it so it's going to be in the ideal position. And how can you better do this? Like really, I would be guessing, and I would have to take a lot more x-rays and do a lot more. This would be a lot longer procedure. This is a fairly short procedure compared to what it really should be, because this has to fit next to an implant, next to the sinus, and come out through the middle part of the bridge. And so we're able to do this. This is a class 3 patient. It makes it way more difficult on a class 3 patient to line things up from the bone. If you've done enough of these, you'll say, okay, that is a difficult procedure to do on this particular case. And so we want to make sure that we hit it and then make it so that it's going to be in the ideal spot. So we're going to turn the implant a little bit. So this is the timing of the implant. So we're going to turn it so that the yellow dot is to the facial, which will help line everything up, because I know the timing of the implant. I had a look at that before we started, and you can see if I get that into that position, then once I put the abutment on, then the abutment should line up better, because we're dealing with compound angles. And when you have compound angles, you have to use the system the way it should be. So I put the facial, the flat part of the facial of the implant out to the facial, so that when the abutment goes in, that it's going to line up properly. Now this is a difficult area to tighten this abutment down. So we'll have two people, and we're actually putting the 3.5 30-degree abutment in, and then one person is turning the torque control wrench, tightening in the screw, because this screw goes through the multi-unit and into the implant. So you line up the hex and you get this all working in your favor instead of dropping it and then the patient swallowing it, or it's not a good thing to swallow. So the temporary abutment goes in, and we can see that this is the next step, is to pick this up and just check the angles and make sure that we're good. And so by putting this on, we're going to use a prosthetic screw that comes with the abutment, tighten it down, and this is to 15 newtons, so you don't want to tighten it down too much more than that, because you will have a bad day if you do that. You'll start to, well, you can just take the abutment on. There's other videos I show how you do that, so you can take the screw out if you fracture the screw. So you can check the channel and you'll find that video, and it'll show you how to do it. So once we get this done, we cut out the old cylinder out of the prosthesis. Never call it a denture. This is not a denture. This is a bridge. So it's actually a transitional bridge. And because it's not a temporary bridge, because it's, it is temporary, but we want to call it a transitional bridge because we're going to use it and keep it in the patient's file, so that if the patient does have a problem with their final bridge, we can put this in at any point and solve their problem in 10 minutes. We can get this fixed. So then before I go back to the patient, we're going to take an x-ray of this, and we had it in chlorhexidine too. So we take the x-ray and just verify that we're in the right position before we start to invest time bringing the resin in and adjusting it. So we go on our OP3D scanner, and this is the CBCT scanner. It does pans as well. And then we'll take that and have a look at it. So I'll finish cutting out the previous abutment cylinder, and then put it back in chlorhexidine. I love my chlorhexidine. We have bowls of this all over the place so you can wash it. We don't want the dust going into the patient's mouth, because that's just not really making sense if you're having open wounds and having all kinds of dust. So we'll try this back in, and we're going to do what's called a pickup of that cylinder now into the prosthesis. So we put this in, and we're going to check and try to find out what the angle is, and we should have a good idea already by looking at the DTX Styudio software. And this allows us to see that we're going to use some quick up. So we'll put some bond on first, and the bond just sits in place, and then we will rub that all over the inside of the transitional bridge with the adhesive. And so once we get the adhesive somewhat semi-dry, then we come and put the bridge back into position. So we screw this down and get it into position so that we can do the actual pickup of the cylinder with the quick up resin. So it's a pretty simple procedure. You do have to play around with it a bit, and if you've played enough with these systems, this will seem like it's pretty normal. You want to make sure you're only tightening this to 10 to 15 newtons. So ideally you would do that. And so once we get this into position, then it's going to be just filling in a little bit of resin around the abutment and doing the pickup, let it cure, and do minimum adjustments. You just want to make sure that there's not a lot of acrylic hanging outside of the area, causing pressure on tissue or problems. But it's simple. If you had an open wound, you put some rubber dam on. Here we don't have an open wound, so we're okay just to do the pickup. So see how there's the space. We're going to fill that space with the quick up resin. So we do want to put some PVS material inside of the cylinder, because you don't want to fill up your cylinder with this material and then not be able to get to the screw to take it off. That is not fun. Ask me how I know. And so just even a little bit can make you lose an hour. So we put the PVS in, and then this allows us to keep the resin out of that screw channel. Trust me, do this. Make sure you do it. So we'll come back and we protect that screw channel, and then we come in with the quick up. This comes with the box, so you can, use the system. You can see when we put it in, it's going to be injected all around the cylinder. And then I'm actually going to put some red resin on, some flowable resin, just to make a semi-fake tooth, even though you don't have to do that, just to make it look a little bit white. This chap is more interested in how many hamburgers he can use with his teeth than looking at that anyway. So he's very interested in function. He wants aesthetics as well. And he just found that his teeth before were just not servicing him. So he made the decision to do an upper and lower all-in-4 bridge. And this is going to service him for a good long time. You do have to keep the implants so that you have 4 millimeters of soft tissue above the platform shift. And so if you don't do this, you're going to pay the price, and so the patient will have an issue. And we can see here that we have that. So we've planned the soft tissue, we've planned where the implant's going to go, we planned how we're going to put it in, all with the software before we start. And so here's my flowable resin fake tooth. So we put that in, and we're going to add that in and make it so it's half decent. So we take it out, making sure that there's no extra resin that's sticking out, but also we can fix the intaglio surface and just make sure that that's smooth and that's all secure. So we come up, we're building a pile of stuff here. You can see that we come back and put the quick up on the inside surface, the intaglio surface. And so take the tip off, get a new tip, of course, because that's already preset. And then this will mix the new resin for you, and then you put it in and just let it set. It usually takes about 4 minutes, I think. And they'll put the timer on to make sure. So you can see that I'm just filling in on the parts that I couldn't get to from inside the mouth. So once we get this done, we're pretty close to being done the procedure, and then we'll let the patient wear this, and they'll wear it for 3 months, and we'll just let that implant heal, and then we'll come back. And he'll still be functioning on his temporary bridges. These are going to work no problem. So we wash it off again with the chlorhexidine. And then you can see here I'm putting the screws in first before I put it back in the mouth. So all 4 screws go in the channel. And then when I hold it on the patient's implants, then I'm able to screw that down with ease. It's a big tip, and Ken Hebel taught me that one. We were working together in Toronto for, I think 2 years, and he was a great teacher for his students, and actually I learned lots of tips from him. And anyway, we put this back in, and I was helping him with the course with Noble Active implants and stuff like that. But you can see once we put this back in, then we were able to position it and then tighten down the screws. And my goal is to get this off fast. So even on the final bridge, I like to put PVS in the channels so that we're able to get it on and off and clean it. So we have them back in every year to clean it, to check it, to make sure the abutments are tight, and to make sure there's no tartar around there, and teach the patient how to clean it, because often they don't really realize that that's what they should be doing. So we have to have them back just to check it and take some x-rays, make sure that the bone's not bad. But the bone on these, for the most part, is really good. I very rarely see a problem. So we put the PVS in the channels. Here we're using some 3M. This is Dr. Scott McLean. I hope you enjoyed this video, and it's been a lot of fun to make this one. Take care.